which is Masterclass on Mental Health Awareness. And we are very happy to launch this issue. And with the help of, thank you, Dr. Ravi Kumar, sir. And I'm sure we will be adding more to this series. We're beginning, it will be on first and third Saturday of every month between 5 to 6 p.m. I want to actually personally take this opportunity to thank you, Dr. Ravi Kumar, because we have been thinking about this for last 2 months, and thank you all the faculty for coming on board. Uh, the webinar, basically, the next webinar, which is on mental health series, is on 15th of June. You can see it's coping with stress in medical practice. So I think it's a must that all of us look at this calendar, which is going to be put up also on our website. And in this webinar, both in the start and the end, I think webinar will end at around 6 p.m. Please give us your feedback, suggestions of topics so that we can add on to this series. Dr. Ravi Kumar?
Yes.
Yeah.
Yes, Aparna.
He is our Vice Chair of Kaho Diagnostic Division. Thank you, sir. Over to you to hand this, this series of mental health awareness, and I'm sure we'll take this ahead with the new parameters of autoimmune and biochemical after November, as we come towards the session of October or November. But I want to assure our participants and delegates that it's going to be a great session. Please share this link and series with your colleagues so that more and more professionals get benefited. So over to you, Dr. Ravi Kumar, sir. Thank you, Kaho, Vijay Agarwal, sir, Dr. Lallu, madam, Dr. Shankar, and also Kaho Secretariat, because we are doing a lot of work in our diagnostic series. So thank you. And without taking more time, sir, over to you. You can take ahead this series. Thank you so much.
Thank you, Dr. Aparna. It's great that we are starting the mental health series with the help of NIMHANS faculty. And I have observed, NIMHANS faculty are committed to mental health. And recently, for the commitment for the mental health, NIMHANS got the Nelson Mandela Award that was received by our director just yesterday from the WHO. And it's a great honor to our country from this. Yeah. So now I request Dr. Aparna, please introduce our one speaker and moderator, and then moderator will take over to this thing. Dr. Naveen, I invite you cordially to this particular session, and also Rini Joseph. Thank you very much.
So we have got a young moderator, Dr. Rini Joseph, who is a senior resident from NIMHANS Department of Psychiatry. Dr. Rini, and I look forward to attend this session. Thank you so much. Over to you, Dr. Rini.
Thank you, ma'am, for the wonderful introduction. So, a very warm good evening to all of you present and all the attendees. We are gathered here today for the first of many upcoming webinar sessions. Today's session is on Introduction to Mental Health. So, it is with great pleasure that I introduce our distinguished speaker for today. We are honored to have with us Dr. Naveen Kumar C., a highly esteemed psychiatrist and a leading figure in the field of mental health in India. Dr. Naveen Kumar is currently serving as the professor and head of the Community Psychiatry Unit in the Department of Psychiatry at the National Institute of Mental Health and Neurosciences, NIMHANS, Bangalore. In addition, he is a consultant for the Forensic Psychiatry Services and Telemedicine Center at NIMHANS. He also holds a significant role as officer in charge at the Center of Excellence on Climate Change and Mental Health, part of the National Program on Human Health and Climate Change under the Ministry of Health and Family Welfare, Government of India. Dr. Naveen's dedication to advancing mental health care is evident through his extensive work and research experience. He is the principal investigator for the National Apex Coordinating Center for the National Tele-Mental Health Program, Telemanas. Dr. Naveen has an impressive portfolio of over 350 publications in peer-reviewed national and international scientific journals. He is also the recipient of numerous prestigious awards, including the Sir C.V. Raman Award for Young Scientist, Professor Raghuram Distinguished Young Teacher Award, the Tilak Venkoba Rao Oration Award, and the Young Minds in Psychiatry Award from the American Psychiatric Association. We are privileged to have him here take this session today. Please join me in welcoming Dr. Naveen Kumar C as he shares his valuable insights on mental health.
Thank you, Rini, and thanks, Kaho, for particularly Dr. Ravi Kumar, who has been our long-term colleague and a friend, to introduce us to this diverse group. What I have been told is that the audience consists of a varied group, including the clinicians, the physicians, the doctors in other spheres of diagnostics and interventions, and even the technicians. So it is a very, very varied group, which is actually good to know. And what is more heartening is to know the interest in mental health by varied group of professional colleagues, which is a very good sign for the country, I would say. But also the challenge is to suit the presentation or talk which can suit this varied group. So I have done some circus and try to include concepts. Basically, in the next 30-40 minutes, what I would be doing is to just introduce various concepts that are there in the area of mental health. Not beyond that. Of course, I mean, the reason is very well known, because individual disorders and other things we actually have till November dedicated to individual disorders. So the objective of this talk will just be to get a sneak into various concepts that are there in the mental health field. I fear that it will be boring, but there is no other way for me to conceptualize this, because its topic is introduction to mental health. So with these things, I straight away go into the presentation. The outline will be to talk about health, and mental illness. What is the burden of mental illness in India? What are the existing mental health systems that are there to tackle these problems? And would end by talking a bit about preventive and promotive aspects of mental health. So the WHO definition of health is known to everybody. I think there is mental. The term mental is there in the definition of health itself. So it is a physical, mental, and social well-being, and not merely the absence of disease or infirmity. So how do we define mental health? So that is one of the principal concepts that we need to understand. Mental health, again, the WHO has given the definition as a state of mental well-being, that enables people to cope with the stressors of life. They realize their abilities and to learn well, work well, and to contribute to their community. So this is a very broad concept of mental health. And as you look at the concept, you also will understand that mental health is just not merely the absence of mental disorders. It is also about how to prevent these disorders, and also how to promote the optimum mental health. So it occurs in a complex sort of continuum, where including the promotional aspects of mental health, preventing mental disorders, treating mental disorders, and rehabilitating those with chronic ones. So these are the continuum that I was talking about. So one also comes across this term called as well-being. Nowadays, wellness centers have mushroomed everywhere. So what is this well-being? So it includes liking most parts of one's own personality, being good at managing the responsibilities of daily life, having good relationships with others, and being satisfied with one's life. So this is the very, very broad concept of what is mental well-being. I not be going into the details of this because of the paucity of time. Is there any questions? We can see if we can answer at the end of the session, or we could take it up later as well. So after discussing about wellness, we come to the definition of what is mental illness. Now there is a legal definition of mental illness also, as given by the Mental Health Care Act 2017, upon which I'll be talking a bit later. Basically, mental illness is characterized by disorders of thinking. That is, our thoughts are disordered, our mood is disordered, our perception is disordered, also a disorder of orientation and memory. it has to be a substantial disorder that of any or all of these things that grossly impairs judgment, behavior, and capacity to recognize the reality or ability to meet the ordinary demands of life. This is a broad definition as per both clinic for the as of now it's applicable for clinicians also, for the legal purposes also. The definition of mental illness as of for today's presentation doesn't include the intellectual developmental disorder that is there in Mental Health Care Act also. The Mental Health Care Act 2017 excludes those with mental retardation, which is the earlier term. The current term is called as intellectual developmental disorders. So the question comes, is mental illness a medical illness? Of course, yes, because advances in genomics and brain imaging have solidified mental disorders as brain disorders. However, one needs to keep in mind there is a lot of societal and cultural and psychological factors that come into play when we discuss mental illness as a medical illness. So, which is why we always talk about the biopsychosocial model of mental health. I am sure that this model can be applicable for all the other lifestyle disorders, particularly diabetes and hypertension, because we know cultural factors, the psychological factors, the social factors, they do play a role in perpetuating the hardcore biological illness such as non-insulin dependent diabetes mellitus. Mental health also is like that. For example, if you take a person with severe depression and alcohol abuse in an adult male, you could see the various biological factors that we keep seeing this day in and day out. What are the biological factors? Maybe in the form of family history of depression in mother or family history of substance use in father. Psychological factors could be the harsh or critical parenting contributing to low self-esteem. The neglect could be there from father and mother due to mental health disorders, being suffering. The suffering of mental disorders that they are experiencing. The social factors could be the parental divorce or broken homes and things like that, which can clearly lead to. So there are biological factors, psychological factors, and social factors. They intermix in various proportions in individual cases to manifest as a psychiatric disorder. Now, let us talk something about the disease entity itself. We all know about what is a symptom. Symptom is something which takes the patient to the doctor. Now, what is a syndrome? It is a cluster of symptoms, repeated clusters of the same symptoms. Those are grouped into the syndromes. A disease and disorder, an established biological cause behind the condition should be there, and disorder and abnormality or injury or disability or aberration when the pathophysiology remains unknown. The etiological factors, as we all medical professionals know that etiology of most of the medical disorders are not yet known. The other medical disorders, at least a pathological point, we have reached up to the pathological, diagnosis, but psychiatric disorders still not reached the pathology level. So we are stuck at somewhere at the syndromic level is what my feeling is. Of course, a lot of research, we know that there is a problem in the brain, but what the exact nature of it, whether those abnormalities can be construed under diagnostic criteria or not, still we are not reached that particular stage. So, then how do we define if there is a psychiatric disorder or not? Two things here we have to keep in mind. One is the dysfunction and the distress, the pain and suffering both the patient as well as the family is undergoing, as well as the dysfunction. There are some role expectations from each one of us, human beings. So if there is impairment, so both of these two things are should be present for one to be called as a disorder. So there are various categories, diagnostic categories. I'll come to that a little later. But the presence of two Ds should be present for us to label any entity as a psychiatric disorder. So how do we diagnose in other medical or surgical specialties versus psychiatry? Of course, we all know history, physical examination, investigations. Then the clinician, will actually try and integrate the findings of each of these things and then come to a conclusion. Here, investigations may not play a very positive role in psychiatric diagnosis. I'm not talking about neuropsychiatric problem, but I'm talking about pure psychiatric disorders. There, the investigations have little role in positively diagnosing psychiatric conditions because many of the psychiatric disorders may be caused by organic disturbances. So the role of investigations in psychiatry is to basically rule out organicity. That's how I'd like to put it. So we are left with history and the mental status examinations. Mental status examination includes observation, sometimes serial observations of patient's behavior, and interviewing the patients and all the other stakeholders to come to any sort of conclusion. This is part of the investigation. Generally, we actually use the CT and MRI and other specific investigations to rule out organicity. So that is about the concept of mental health and illnesses. Now we'll just discuss about what is the burden that mental illness is causing in our country. The first time a nationwide survey, which is called as the National Mental Health Survey, occurred in 2015 and 16. Professor Ravi Kumar also was there in the institute as Professor and HOD of Neuromicrobiology when this survey took over, which NIMHANS led. There, about what we found was across India, about 10.6% of the population of India had one or the other mental health problem, that's mental disorder. That's about 15 crores. You can imagine the number we are talking about. I mean, that I think now some reviews have come, some meta-analysis have come later on, which puts this to 14%. So that is the burden that we are talking about. You could also see, this slide is just a repetition of that with some other details. So there is also, you all know about the disability adjusted life years lost. The DALYs, attributed to mental disorders has increased from 3% to about 5%, from 1990 to 2019. So we are actually faced with a growing menace is what I would say from the mental health problems. And not to talk about suicides, there is increase in the rate of suicide and major causes include family problems, marriage related interpersonal issues. Students, there are a lot of stress that is being faced by the students across the country. So attempted suicide is of course 20 times higher. So that is the thing that we are talking about. Then the issue of substance use problems in the country. So about 3 crore users of cannabis in the country. This actually is commissioned by the Ministry of Social Justice and Empowerment, Government of India. Alcohol use, about 16 crore of them use, but then 5.7 crore problem users are there, about 3 crore dependent people are there when we talk about alcohol. Opioid also about 2.3 crore users, and 28 lakh dependent people. So we are talking about the huge problem. And this concept called as a treatment gap. The treatment gap measures the proportion of people who are not on treatment for any of the mental disorders. So this ranges between 70 and 86%. Essentially, that means 4 out of every 5 persons diagnosed with mental disorders, they don't have access to treatment. That is the meaning of the treatment gap. This figure, of course, is about almost 8 years back. That was in 2015-16. On a positive note, I would like to say that there are a lot of interventions that have occurred in the past 10 years, which I'll be sharing with you a bit later. Also, a mental illness is very, very intimately related with other medical comorbidities, such as particularly the lifestyle disorders, the diabetes, dyslipidemia, and hypertension, and things like that. It is a bidirectional relationship wherein those with chronic illnesses have been shown to have more chances of developing diabetes or hypertension, and vice versa. Also, a lot of literature on that. This is not only related to chronic lifestyle disorders, but also it is true with COVID. That also I'll be talking with. COVID is hardcore infectious disease, isn't it? But even then, we all know what mental health related problems it caused, and also it's a cross-cutting issue. When we say cross-cutting, multiple sectors are involved, which directly affects mental health. For example, urban migration, particularly to urban environments, the NCDs, the climate change everywhere. The buzzword is climate change, and that has a lot of impact on the mental health, child and adolescent health, women, poverty, unemployment. All these things, they interact in a complex fashion to, cause mental health problems. And I was saying hardcore infectious diseases also, like for example, COVID. There are nationwide surveys which showed prevalence of huge mental health problems in the country. up to 35% of the people, particularly during the lockdown, they experienced one or the other kind of mental distress, or I would not say disorder, but a huge proportion of the population, they experienced mental health issues during the COVID. The long-term effect also, I think some of the mental health impacts are there. I will not go into the details of that. So now we move on to a classification of mental disorders. Very broadly speaking, mental disorders are classified into those with severe mental disorders, common mental disorders, substance use disorders, and personality disorder, and developmental disorders. Developmental disorders, they have their onset in the early childhood, sometimes the before birth itself. Some genetic causes of developmental disorders are there. So since birth, they have this issue. So examples of developmental disorders are attention deficit hyperactivity disorder, autism, and intellectual developmental disorders. I cannot go into the details of these things because child psychiatry experts will come and engage you with all that. Personality disorders are some other category. I will talk about it a bit later. Substance use disorders, including alcohol, opioid, tobacco. These are the three substances. But nowadays, we are coming across various esoteric substances. The number has increased. The kind of different substance use problems, particularly the young people, come to treatment. When we talk about common mental disorders, major depression, generalized anxiety, and obsessive compulsive disorder. Severe mental disorders, quintessential schizophrenia, as well as bipolar disorder. They are called as SMDs and CMDs simply because there is a difference in the prevalence. CMD is much more prevalent, maybe in India at the current rate, about 5 to 6% of them have experienced a CMD. While SMD, usually the worldwide prevalence is about 1% or a tad less, about 0.8, I would say. So that is the difference between CMD and SMD, but much more dysfunction is there, obviously, in severe mental disorders when compared to the common mental disorders. So when you talk about severe mental disorder, usually the three category of symptoms we say, because one other thing that I'd like to say, as I was telling previously, when we talk about psychiatric disorders, we all have to depend on the symptoms. The collection of particular symptoms in each patient is what we look at. So in schizophrenia, basically the disordered thinking is a primary issue in schizophrenia. How do we get to know which thoughts are disorder? What are the disordered thoughts? So there could be multiple delusions, there are false, fixed, firm beliefs, which is not shared by the people of the same socio-cultural origin. They can have perceptual disturbances in terms of hallucinations in various sensory modalities, but most commonly in the auditory modality. There is disorganization in speech as well as behavior. So those are the positive symptoms that we can come across in schizophrenia. Negative symptoms in terms of amotivation, reduced speech, reduced interest in day-to-day activity, those kinds of negative symptoms are there. Cognitive symptoms in the form of deficits in concentration. They have poor working memory and things like that. It has to be, the schizophrenia is known to be a continuous illness. Of course, etiology, I will not go into the details because we will just stick to the biopsychosocial model, but the severe mental disorders, there are more biological factors that are implicated rather than the psychosocial factors. Psychosocial factors in severe mental disorders, they can act as precipitating factors, and they may impact their outcomes rather than being direct etiological factors. That is what I'd like to say. That is about schizophrenia. Duration 6 months, minimum should be there, is what the current diagnostic criteria would say. The treatment aspect also is actually more or less it follows the same pattern. That is, the medication therapy is there. Then the psychological therapies, such as the various kinds of psychotherapies, is what we say. Social support and community level treatment in terms of managed care, assertive community, and so many kinds of outreach services are there. Because this persons with schizophrenia and sometimes bipolar, they have to deal with this lifelong, and hence lifelong support is required for them. In developed nations, there are systems to reach out to them even when they are living in the community. Our systems, they have not yet reached that level, but actually they are improving. And the Mental Health Care Act has obligated states to come up with these kind of systems. So things are changing for the better is what I would say. Lifelong support in the form of support groups or vocational disability benefits, vocational placements, and so many things in the rehabilitation realm are the treatments for. The other when you talk about so that's about schizophrenia. Bipolar, it is called as bipolar because it is characterized by two phases. One is the manic phase, in which the bipolar disorder, the actual basic premise is the dysregulation of the mood state. That is the thing. So sometimes the dysregulation takes the man to become very irritable or very happy for at least a week or so without any actual reason. And then the psychomotor activity increases, and a host of other behaviors are seen as secondary features. The primary feature is the dysregulation of the mood state. Manic, and the quite opposite is the depressive phase, wherein the mood is depressed and a whole lot of other symptoms are present. Of course, when I talk about depression in next tour, one of the sessions I saw is about depression, so I'll talk in more detail about depression then. Here also the etiological factors, both biological as well as psychological and psychosocial factors are there. Treatment. Good treatment modalities are available in terms of mood stabilizers. Valproate is one of the very good mood stabilizers, I would say. Antipsychotic medications. In bipolar disorder and schizophrenia, the other thing which is left out here is the electroconvulsive therapy. And nowadays, a whole lot of other non-invasive brain stimulation techniques have come. For example, repetitive transcranial magnetic stimulation, transcranial direct current stimulation, transcranial alternative current stimulation. These are for the severe mental disorders. For other anxiety disorders like OCD, deep brain stimulation is another psychosurgery technique that is being used now more often. So a whole lot of biological treatments along with psychological as well as psychosocial support, they do exist. The substance use disorder, I would like to just, although I've mentioned three here, I just like to discuss about alcohol use disorder, because the basic principles are the same to the clinical features. How do we recognize the alcohol use disorder? Irresistible urge to take the substance, that is craving. It could be precipitated or non-precipitated. Craving should be there. These principles are to be present in all disorders, in all substances. That's why I'll not go. Also, the time, I am just having a look at the time also. I don't have much time, so I'll just rush through. So loss of control over drinking should be there, which means drinking more and more for longer than initially intended. That should be present. And when there is sudden stoppage of usage, there should be withdrawal symptoms in terms of tremors or anxiety, nausea, seizures, etc. Salience, that is the importance, the activity of consuming substances, that activity takes precedence over all other role definitions of that particular person. So that should be established. Tolerance, that is needing more and more substance to achieve the same effect. And despite knowing the harm that the substance has caused, if the person continues to use. So these things should be present. 3 or 4 of these things should be present for at least 6 months or 1 year for any person to be called as substance use disorder. So medication-wise, the detoxification, we require medication. Also, we use anti-craving drugs in terms of naltrexone, acamprosate, and disulfiram. Various psychological therapies, including motivational interviewing, enhancing the motivation, the CBT, and so on and so forth. And substance use disorders also are called as chronic relapsing and recurring disorders. So many a times substance use disorder persons and family, they also require lifelong support. For that, I think there are many organizations in the community. The health systems also will have to gear up to that. So I'll not go into the details of the opioid use disorder as well as the tobacco use disorder, keeping in mind the time. Common mental disorders also, I'll take just one. I'll just take one disorder, that's obsession and obsessive compulsive disorder. Obsessions are defined as recurrent, persistent, intrusive thoughts, urges, images, or fears. These are unwanted images, unwanted thoughts. People try to control them, but unsuccessfully, and they cause a lot of fear. They don't want these thoughts. They know that these thoughts are silly. They know that these thoughts and fears are useless. They have that insight, but they'll not be able to control them. That's the feature of an obsession. Very commonly, doubt about contamination, aggressive thoughts. Sometimes patients we have seen, they do get repeated unwanted thoughts about very, very close people, like for blasphemous thoughts against the deity they revere, or very ugly thoughts about someone they respect a lot. But they're not able to control, which is why the distress is there. That is obsession. The compulsion is the repetitive behaviors or mental acts that an individual feels driven to perform in response to an obsession. They are time consuming and they are associated with significant distress and impairment. For this also, a host of medications are available in terms of SSRIs, that is the selective serotonin reuptake inhibitors. A lot of psychosocial and psychological measures are required for persons to treat OCD as well. I'll just skip this anxiety disorder. I'm sure there is a separate session on generalized anxiety and anxiety disorders as well. Childhood and adolescent disorders, as I was saying, ADHD, it should be seen in the childhood itself. They should be the symptoms consisting of inattention, hyperactivity, and impulsivity. They have to be present at least for 6 months. Again, etiology, all the factors are essential. I cannot go into the details. The treatment principles also are the same, both using the medications as well as psychological and psychosocial techniques and social support. Autism, I think nowadays more and more people are hearing about autism. The predominant problem is the deficit, the social development of a child. And majority of the times it's also associated with intellectual disability or intellectual developmental disorders. They also have restricted interest in repetitive behaviors or they're called as stereotypies. It is a lifelong condition evident early from the childhood. A strong biological and genetic component are there. There is no cure for autism. So it is all about adjusting the social environment to suit the strengths that are already there in the child and try to help whatever is there. And that is a long-term process. And of course, there is a separate session on child psychiatry also. IDD, of course, a lot of cognitive impairments in adaptive functioning. There is delay in development, etc., etc. A lot of what I would like to say is this: people with ASD, ADHD, and intellectual developmental people, they also can develop other severe mental disorders or common mental disorders. That kind of comorbidity also is very well known. Of course, the treatment also are multiple levels of treatment are there for those with ADHD. As early as possible, the speech therapy and so on and so forth. I think the needs are so many. I don't see the point in explaining all that because of the paucity of time. But I want people to know that these things are available and it's an issue with long-term engagement. Now, personality disorder, how do you define the personality? I mean, it is an enduring disturbance manifest in the patterns of the person, patterns of thinking, feeling, and behaving. They are actually maladaptive, inflexibility and poorly regulated, and manifested across a range of personal and social situations lasting for more than 2 years. These are difficult constructs to diagnose, and I think it's difficult to explain everything in one. I mean, of course, how to understand the personality? Personality is a characteristic way individual thinks, feels, and behaves. That's what I can say. But usually what happens, it will be an adaptive way of thinking. Adaptive in the sense, adaptive to the needs. When we talk about the needs, we always talk about the societal needs, and we have certain roles for us to perform. But when these patterns they go maladaptive, that is when the personality disorder comes. And one defining feature of a personality disorder is that there should be absence of all the psychiatric disorders. If the particular pattern of thinking and feeling if it can be explained by a psychiatric disorder, then we don't diagnose personality. So that is where I'd like to stop. There are various kinds of personal disorders. Now ICD-11 has changed this concept. So I'll just skip this. Again, when you come to treatment, it's a long-term issue. Both therapy as well as medications and community level support is required for those with personal disorders also. So this is a brief, very superficial, I would say, overview of psychiatric disorders. And when you look at mental health systems, in fact, India was one of the first countries, at least in the Southeast Asian region, to talk about a national program for mental health. It started as early as 1982. The approaches and objectives was to integrate the mental health care into the primary care. That is what I'd like to say. And it got operationalized in the form of a district mental health program to provide sustainable mental health services, at least in the district level. So, as I was saying previously, though the beginning was very slow, there is rapid development in the past 5 years, wherein now the DMHP or the district mental health program is actually operational in more than 700 districts of the country. And wherein at least a team of 4 or 5 people are available at the district to provide detection and treatment, free treatment for those with psychiatric disorders at the district level. Still, there is a lot more distance to travel, but at least we have come this far. The other mental health infrastructure in India, there are 47 mental health institutes, so-called mental hospitals. Earlier, they used to be called as psychiatric asylums. But nowadays, it's a stigma. I mean, we should not use such terms, but because of the fact that they are there, they were there existing, I just told that. There are psychiatry departments in most of the medical colleges, as you are aware, about 500 medical colleges. They do have psychiatry departments. And 120 PG departments were upgraded. Departments of psychiatry is there in all AIIMS in the country. Out of these 47 mental hospitals, 25 have been supported as centers of excellence, wherein they are offering PG courses. And there are 3 central mental health institutions, including NIMHANS, Central Institute of Psychiatry Ranchi, and LGB Institute Tejpur. So other system which is there is, actually we are a bit late, but we have a national mental health policy that came in 2014, which is quite comprehensive document, which talks about having universal access to mental health, comprehensive service use, access to vulnerable groups to reduce the risk factor. It's very, very comprehensive, So we have that policy as a roadmap for us to follow. And then there came a Mental Health Care Act, which is a right-centric approach. Now it has become the right of every individual in the country to have access to decent mental health care. That is why I was saying that there is obligation for all the states to come up with some services at the district level. Otherwise, the state has to compensate. That is what is written in the law. And there's a whole chapter dedicated on rights of persons with mental illness. The chapter 5. There are some 10 sections from section 18 to section 26 or 28, I think. So they all talk about what are the rights of persons with mental illness. There are mental health review boards that are set up at the district level to monitor the mental health services. There are provisions for advanced directives. There are statutory bodies in the form of state and central mental health authorities to monitor the registration of mental health professionals and mental health establishments. The suicide attempts have been decriminalized. Those are some of the there are provisions for emergency treatment in the community for those with psychiatric disorders, like non-modified ECTs. Unmodified ECTs are totally prohibited. ECTs for minors have to be given with prior permission of the board. Sterilization as a treatment procedure, which was in practice earlier, that has been prohibited. Chaining and seclusion, all these things have been prohibited. I'd like to end by talking about the new kid on the block. It is known as the Telemanis, or the Telemental Assistance and Networking across states. It is the program from the government of India to buttress the existing DMHP. Telemanis is called as the digital arm of the National Mental Health Program. And as on today, almost 1 million calls. In fact, that has been surpassed about 2-3 days back. This presentation was prepared 2-3 days back. That's why they have not crossed 1 million here. People can call from anywhere they are. 14416 is a toll-free number. It's a free service, which is the service is being run by all states and union territories which have the state Telemanis cells located. 1 or more cells are located across each and every union territory and state of the country. And most of the places, they are getting 24/7 services. For the counselors are there for providing services at the first level, which they, if they are not able to if they're not able to sort out the problems, then the calls get escalated to mental health professionals. And we are working towards integrating these audio kind of service to having the video call with, eSanjeevani is already there. The talks are on to blend the Telemanus IT architecture with eSanjeevani so that there can be a seamless switch from audio consultations to video consultations. And of course, this also efforts are being taken to network with other in-person services, the in-person services that I've talked about already. So whichever nearest places are available for those people whose problems are not solved with either audio or video, there is provision to refer to the nearest in-person services also. This is the broad, functioning or structural organization of Telemanus. So this I was telling Tier 1 and Tier 2, wherein the counselors as well as the specialists are there to create. And there is a National Suicide Prevention Strategy also. It is a comprehensive policy which was actually due for a long time. Now we have some strategy at the national level. Now it gives some sort of a guidance for the states to follow, which aims at reducing the incidence of suicide through coordinated efforts, be it early intervention, be it supportive legislation should be there, is what is written in the strategy. There is focus on increasing the awareness and to improve the services. So I think the target set is 10% reduction in the incidence of suicide by 2030. That is the target which has been set. So last part of my presentation is one should also know about mental health promotion. That involves action to improve psychological well-being. This initiative include, of course, it does not just pertain to what we can do, because it's a very broad thing. And sectors like housing, education, workplace, and sports, and so many other sectors are to be involved, to promote mental health of individuals. It's not an individual action. And about a slide or two about the prevention. Mental illness, some mental illness can be prevented through various strategies. The WHO also has advocated for this. Like, for example, what are these preventive interventions? Nurturing care and parental support. It could be school-based programs like life skills education is one example to prevent bullying, constant bullying. Access to education and employment opportunities. These are some of the things. And strengthening social networks and community engagement, substance use prevention programs in the form of awareness campaigns. One thing I'd like to share here is a massive awareness campaign and massive IEC activity that is given for tobacco control. Now we know the incidence of tobacco dependence has come down. So that kind of approach has to be taken for mental disorders as well, particularly substance use disorders. And of course, treatment programs should always be there. Stress management programs, workplace wellness program. These are some of the topics that are actually gaining force nowadays. And of course, policy and legislation also have to be supportive. So self-help strategy in forms of physical activity, mindfulness, and so on and so forth. I've just listed some of these strategies for mental health promotion. So these are some of the things that one can have. Of course, it may seem commonsensical, but very, very less number of people do follow it. And for those who are interested in technology, there is this Manas app, and there are so many hundreds of apps, but actually NIMHANS has actually worked on these things. So authentic source. So one can visit one of these things to get help with regards to promotive as well as preventive manner. So I just like to conclude by saying that mental health is a very, very broad topic, and it's impossible to cover everything. So it involves promotion, prevention, treatment and rehabilitation strategy. It is a cross-cutting issue, as I've told. There is significant progress in recent times that have been made in terms of NMHP, DMHP, Mental Health Policy, Mental Health Care Act, and the Telemanus. I'd like to all of you to remember this number and please promote it wherever you can. And we would be happy to share a lot. And in fact, NIMHANS is the Apex Coordinating Center for Telemanus, and we are actually working with all the states and union territories to make this into a success. Now we are actually getting nearly 3,500 calls a day throughout the country. So 14416 is the number to remember and spread across. We can actually share a lot of IEC materials if you could promote it in your all programs. So I would like to end by saying there is no health without mental health. These are some of the useful links for additional reading, and these are the people who have helped in preparing this presentation. I'd like to thank and acknowledge Rini, Prerana, Aditya, Meghna, and Maryada for taking their time out and helping me put in these slides. These are some of the references. Thank you very much. I would like to stop here and see if there are any questions. Thank you.
Thank you, sir, for such a wonderful, concise presentation on the introduction to mental health. I'm sure all of you have got an overview of what all entails and what are the different aspects when we talk about mental health. So now we can take up some questions that are in the chat box.
Yes, sir.
Hello, can I say something? Am I audible?
Yes, Dr. Rima.
Yeah, hi. First of all, I really want to congratulate for starting this series on mental health. It's really good, and Doctor especially for giving such a wonderful talk. And only one question. If you could add a little bit or enlighten a little bit on Mental Health Act and the person, his rights with the mental health. So could you please throw a light on that and also display the slide?
I'll just do that. The rights slide, no? So Chapter 5 of the Mental Health Care Act 2017, it's about the rights of persons with mental illness. It says right to access mental health care, right to community living, right to protection from cruel, inhuman and degrading treatment, right to equality and non-discrimination, right to information, right to confidentiality, and restriction on the release of information in respect of mental illness, right to access medical records, right to personal contacts and communication, right to legal aid, and right to make complaints about deficiencies in provisions of services. These are the broad sections that are there in the Chapter 5. So actually it's kind of an obligation now for the states to provide services, at least at the district level. And a lot of review boards, mental health review boards have been set up to just monitor this. And patients are free to complain to the review board against any rights violation that they may perceive. Like, for example, in our hospital, we have had a couple of patients complaining against the service, and we have directed them to the mental health review board that is functioning in our campus. And so the review board is actually chaired by a district level judge, either retired judge or the serving judge. Also in many of the states, the serving judge also have been made chairman. He is a chairperson. It's a quasi judicial body, and the board consists of other members in terms of social workers, psychiatrists, members from the users, as well as members from the caregivers. So they take it up and see if there are any violations or not, and they pass the orders. There are provisions for admitting persons involuntarily, and if the patient is not agreeable to that admission also can be challenged. It has now become akin to what the systems are there in the Western countries, wherein the admissions also can be challenged. So in that sense, it has become a rights-based approach is what I would say.
So I think your question is answered.
Thank you so much. Yes, Dr. Naveen, thank you so much. And yeah, it's nicely answered. I also wanted to know about the legal rights of a patient who's having mental disorder on, the right to property and his from his, inheritage property and things like that.
Thanks for the question, ma'am. I think that is not answered in the Mental Health Care Act. Actually, it is answered in the other act, which is known as the Rights of Persons with Disabilities Act 2016. There, what it says is it provides for guardianship, both limited guardianship as well as complete guardianship. So that is a bit of a complex process. Now, I think the courts have to get involved. The the family members or nominated representatives will have to appeal to the court, and court has been vested with the authority to grant the guardianship. The limited guardianship is for only certain specific issues, as you were pointing out. For example, if the person has the capacity or not to undertake decisions related to disposing the property. So that has to be first evaluated by a group of professionals, and based on that, the court will give limited guardianship only for that matter. Complete guardianship, there are so many other procedures. For example, the severity of the disability caused by the illnesses should be so high, and it should be decided that the person is not in a position to take care of any of the tasks that are essential for living one free life. So those are the two concepts that are there, which is actually comes under RPWD. I guess the systems are still to be robust in our country, but at least the legislations are there, the rules have come out, and we need to wait for some more time before these systems become good enough, and the accessibility, many people aren't even aware of these things. But I think the courts have been vested with the authority for granting the guardianship.
Yes, sir. Thank you so much. Just to, just share, sir, I think you are well aware that the Mental Health Act is very poorly implemented in our country.
Yes.
And it really calls the domain doctors to really raise a voice on this, take lead, and so that patients who are suffering, they are not devoid of their rights.
Agreed, ma'am.
Yeah. Thank you so much for
Thank
the
you.
talk. Truly
Thank you.
appreciate it. Thanks.
Thank you.
So we'll take another question, which is like, how can we help a colleague who is suffering from mental health issues but not willing to seek help?
I think the very easy answer for that is, they can call 14416. If they're not willing, I think it's a difficult question. But since Telemanas is actually a robust system, at least they can try once, and if they're not satisfied with that, we can look out for other things, because it's a confidential service. The counselors are there 24/7. They are well trained, and the day-to-day issues or the mental distress part, they can actually take care. That is one thing straight away they could do as of now.
Some more questions are regarding the Mental Health Care Act. So there's a question: is state mental health formed in all states? Because certain states like Pondicherry.
Yes. I see. Actually, most of the states, the mental health authorities have been formed. I think the latest that I know is about 22. We are also working with the states, and I think about 3-4 months back we had this data. Out of 36 states and UTs, 22 of them have formed state mental health authorities. Actually, I'd like to share one thing, because before this Mental Health Care Act 2017, there used to be the act called was the Mental Health Act of 1987. Under that, not even 5 states had established state mental health authorities, even by 2002-3. So in that sense, thanks to the Mental Health Care Act, the authorities, I think the state authorities are being formed, and many states have formed mental health review boards also. So that is the kind of fastness with which these statutory bodies are getting established, and I'm sure in the next 1 or 2 years, the entire country will have these statutory bodies.
Yes. And another question is, how can people diagnose this in early stage itself? So by this, I think they are asking about mental health issues. How can they diagnose early?
Yeah, I mean, see, the one of the things that they should do is to observe any deviance in the behavior. In the sense, the expected role varies according to the developmental stage of the individual. And if the observed role is not being performed, that is when some bell should ring, and then they should expose themselves to a thorough assessment. And that is how we could think of diagnosing early. I think there is no other way, and they should be first aware, and then expose themselves to the assessment.
And some questions on specifically for ADHD, of how early diagnosis is possible in ADHD, what treatments for multiple substance abuse.
ADHD now is a kind of abused term. If you look at the Western literature, 30% of the kids or even more, they are diagnosing ADHD. But ADHD is an issue. There's no doubt about it. So again, the behavior of the child in terms of being hyperactive when compared to the other siblings, that should ring the bell. Or compared to other child which is there in the neighborhood or something, the normal developmental activity. When you compare that, you will come to know that there is something wrong, or there is inattention, inability to concentrate for some time. Are there impulsive activities that the child does? So these are some of the clinical features that the parents will have to be aware and get the child evaluated. And of course, I'm not a child psychiatrist. There is a special separate session on child psychiatry. They would be able to give more comprehensive details.
And who is the chairperson for district mental health program? And is there any role for nurses in the district mental health?
Oh, yes. It's not a chairperson. Let me call it a team lead. The team lead is a psychiatrist. Of course, out of the 700 odd districts, I don't think half of the districts do have psychiatrists. Many of these places are being led by doctors trained by NIMHANS only at the district level. So psychiatrist is supposed to be the leader of the district mental health program. And the team also comprises of psychiatric nurses, not only psychiatric nurses, clinical psychologists and social workers. In fact, the 2 nurses are being made available in the Government of India guidelines for district mental health program. Of course, nurses are part and parcel of the team. There's no question about it.
Yes. And some light, if you could shed some light into the facility requirements as per the MHCA for psychiatry hospitals.
I think there are regulations that have come out in the form of central mental health regulations, which clearly lay down the guidelines for, they are called as minimum standards for mental health establishments. Those I don't think we have the time now to discuss about it. It's available in the public domain. If you just type central mental health regulations for Mental Health Care Act, they would specify. Based on these central mental health regulations, the states are actually preparing the state-specific regulations. So that is where I'd like to stop, and because of the paucity of time. But in that, they talk about providing wholesome food, what should be the doctor psychiatrist to patient ratio, what should be the dimension of the room, where the toilet should be located, how the toilets, all that, ventilation, suicide prevention measures, all these things are discussed in those regulations.
I think we can take the last question as what in the present Indian scenario post-COVID, many children are affected by global developmental delay, autism. Is it anything to do with COVID?
This I would say I don't know. I'm not the expert in that. And COVID has wreaked havoc in all spheres of our lives, including there are people talking about long-term COVID effects. But whether it has any specific effect on autism, I'm sorry, I should get back after reading. I don't know.
There's a session on child, especially.
Right. Maybe there they would get the answer. Thank you.
So thank you all for raising interesting questions for this discussion. I'll hand it over to the organizers for further requirements.
Thank you, Dr. Naveen. And
thank you, sir.
Dr. Rini.
Thank
Wonderful
you.
Presentation. Really, all the participants have gained a lot of knowledge about introduction to mental health. And we will be seeing the mental health other topics every Saturday, first Saturday and third Saturday of every month. So that would be great if you people can throw light on the various aspects of mental health. Even after November, we would like to continue with the various laboratory aspects related to mental health and other things. So on behalf of CAHO, I thank both Dr. Naveen Kumar and Dr. Rini for conducting a very smooth and very informative, knowledgeable session of today's. Thank you very much.
Thank you very much, sir, for having us to this. Really appreciate. Thank you.